Hello, I'm Chris Fleming, Health Affairs Forefront Editor. Welcome to today's Health Affairs Lunch and Learn, the Affordable Care Act at 12. As the title suggests, the ACA just celebrated its 12th birthday. I recently heard one of today's speakers refer to the ACA as resilient, and that's an apt term. Remarkably, given its history, the ACA is currently free of existential legal threats. Enrollment in the marketplaces are at record highs, with millions more enrolled through Medicaid expansion. During a global pandemic, the ACA helped keep the uninsured rate stable and facilitated coverage of testing and vaccines for COVID without cost sharing. The Biden administration has been able to build on the Affordable Care Act through administrative and legislative means. Most recently, it issued the proposed rule addressing the so-called family glitch. And of course, the ACA is integrated into so many aspects of our health system, not just the marketplaces and Medicaid, but the Center for Medicare and Medicaid Innovation, the biosimilar regulation, and even back to insurance, the very way we think about insurance and coverage. On the other hand, the ACA still faces major challenges. The subsidy expansions in the American Rescue Plan Act that enabled the higher enrollment are set to expire in a few months, and they have not yet been renewed because of the lack of progress on the Build Back Better Act. The eventual expiration of the COVID public health emergency will cause perhaps some difficulties on the Medicaid side, with millions of enrollees facing, for the first time since the emergency began, eligibility redeterminations, and people could lose coverage. And if polls are to be believed, the Republicans could take back control of Congress in a few months, which would, of course, intensify political headwinds for the ACA. And of course, those would get even more severe if the Republicans picked up the White House in 2024. Even if outright repeal and replace were not on the table, you'd still have the possibility of a death of 1,000 cuts, such as occurred during the Trump administration, with declining enrollment as a consequence. In a few minutes, I'll introduce today's speakers. They'll each provide some opening remarks, and then we'll go to Q&A. And I'll remind folks later, but I will say that you can enter your questions using the Q&A tool on the bottom toolbar, and then we will get to as many of those as possible. Our first speaker will be Katie Keith. Katie provides, following the ACA, rapid response for Health Affairs Forefront. She writes the Eye on Health Reform columns in Health Affairs Journal, and is also the author of our recently launched Health Reform newsletter series. Her work has been cited often, a notable example being the prominent citation by the IRS in the proposed family glitch rule. She is the director of the Health Policy and Law Initiative at the O'Neill Institute for National and Global Health Law at the Georgetown University Law Center, consumer representative at the National Association of Insurance Commissioners. She's an active, as if that wasn't enough, she maintains an active healthcare consulting practice, and she's the co-founder of Out to Enroll, a national initiative to connect LGBTQ+ people with coverage options. Our next speaker will be Rodney Whitlock. Rodney is a vice president in McDermott Plus Consulting, where he advises clients on issues involving federal programs such as Medicare and Medicaid. Rodney had a distinguished career on Capitol Hill in key health policy roles. He began his Hill tenure as health policy director for Representative Charlie Norwood, Republican of Georgia. He then moved to the Senate, first as a health policy advisor on the Senate Finance Committee staff, then as the health policy director in the Office of Finance Chair Chuck Grassley. Rodney was a leading GOP staffer on the Patient Bill of Rights, the Affordable Care Act, and many other pieces of legislation. For the last 20 years, Rodney has been an adjunct faculty member at the George Washington University Milken Institute School of Public Health and GW's Graduate School of Political Management. Our final speaker will be Tim Jost. Tim was our original rapid response health reform blogger. He chronicled the passage and implementation of the ACA on Health Affairs blog until handing off to Katie in 2018 after nearly 9 years and more than 600 posts. Tim retired as the Robert L. Willett Family Professor of Law at the Washington and Lee University School of Law. He's the co-author of a casebook, Health Law, that is widely used throughout the United States. And he's also the author of a treatise and hornbook by the same name. He has written multiple books in the health policy field, and his work has been cited in media outlets and other places too numerous to mention. So on a personal note, before we go on, I do want to say that working with Tim and Katie has really been one of the highlights of my professional life. I mean, the immense time and effort that they put into helping people understand the ACA and health reform more broadly has certainly been a great service to health affairs, and I think more broadly to the health policy community and to the legislative process. I've been honored and thrilled to be a supporting player in that endeavor. So thank you to both of you. And with that, I'll turn it over to Katie.
Great, thanks so much, Chris. And it's thank you to Health Affairs for doing this. I'm extra delighted to also be with you and Rodney and Tim. And even from your opening remarks, Chris, I think we share a brain because there's a lot of overlap and similarity there, which is not that surprising because you were my editor. So I'm very happy to be here. I'm one of the people that have used the word resilient. That's the word that comes to mind for me when I think about the Affordable Care Act and where we are 12 years in, whether it's been efforts on Capitol Hill to repeal the law, states refusing to enforce or implement the law, efforts by the Trump administration to undermine it using executive action, or the three existential legal challenges that we've seen through the courts that are very near and dear to my heart and Tim's heart. The law is still standing, and 12 years in, it is thriving. It really is the strongest it's ever been. Chris, I think you had some of those great data points, and I'm going to drill down probably even further. So we've got record high enrollment, both through Medicaid and the Affordable Care Act marketplaces. Congress built on the Affordable Care Act for the first time ever through the American Rescue Plan Act last year. The Supreme Court threw cold water on the weakest legal challenge that we've seen so far in a resounding 7-2 decision, sort of saying, please don't bring these. And something I'm looking forward to Rodney's take on, including statements by one of his former bosses. Republicans in Congress are really saying there's not a lot of appetite to revisit repealing and replacing the ACA, even if Republicans do take back one or both chambers in the midterm elections. Even those like Senator Johnson, who have maybe hinted that that could be a possibility, they've sort of walked those comments back. And I'm also mentioning Senator Grassley as well. So it feels like a sea change for the Affordable Care Act. So really want to build that out. So those who read the Following the ACA series under me, I think know that I can sort of wonk out with the best of them, but I'm going to keep my comments pretty high level and focus on some of the data points that I do think will ground the discussion. And I'm very much looking forward to Rodney's remarks from Tim, and then the Q&A itself. So maybe if we could go to some of the data. I sort of pulled the 5 data points that I think you have to know to really understand the ACA at 12. The first is something folks are probably pretty familiar with, but we have seen a record low uninsured rate thanks to the Affordable Care Act. So ever since the law was enacted in 2010, there have been ongoing declines in the uninsured rate, reaching a record low in 2016, the last year under the Obama administration. After that, under the Trump administration, we did see the uninsured rate tick up. There's a whole lot of reasons for that we could discuss. I do attribute it to some of the policies under the administration to limit or discourage enrollment in Medicaid and the ACA marketplaces. Even so, we're still much better off than we were pre-ACA, so something really important to keep in mind. The slide I put in front of you is only data through 2019. That's in part because the post-2020 data, given the pandemic, is a little bit noisy, but as Chris mentioned at the top, the uninsured rate has been remarkably stable. We have not seen these sort of significant coverage losses that could have been catastrophic, I think, in the absence of the Affordable Care Act. You really had the marketplaces, and I would say especially Medicaid, serving as this really strong coverage safety net and sort of a soft landing spot for folks who might have otherwise been uninsured in a prior economic downturn, having somewhere to turn for their coverage. The provision of Families First, a bipartisan law passed by Congress in 2010, is also doing a lot of work there, I think. I know other folks are going to talk about the end of the public health emergency and this fact that states have not and cannot, if they want to receive extra federal funds, disenroll people. And so we've really seen Medicaid grow significantly to record highs in the past 2 years or so. If you go to the next slide, I think you cannot talk about the Affordable Care Act without talking about how it has narrowed racial and ethnic disparities in coverage and access to care. And so this is data from the Commonwealth Fund that really shows the progress that's been made so far on reducing the uninsured rate for Black and Hispanic people in particular. You know, we have seen gains. There's a lot more work to do, as you can see from that slide. There's still disparities that exist. And if you have not read it yet, I would highly recommend Health Affairs' recent issue devoted to racism and health about all the work that we really do have left to do to make a difference. But we have seen significant progress under the ACA. And I think it's really worth kind of shouting about that and talking about it. Chris mentioned that I also do a lot of LGBTQ health work. And I would say that you've seen a very similar trend for sexual and gender minorities as well. Huge coverage gains, but still disparities that we have to really get under control. I think my editorial note about this slide is that Medicaid expansion really has done an incredible amount of work here. And I'm concerned that we're not actually going to be able to narrow the disparities that you can see as much as we could if we don't get Medicaid expansion in those 12 holdout states that have not yet expanded their programs. 60% of the people in the Medicaid coverage gap in those 12 states are people of color. And it's one of the reasons why champions of this issue on Capitol Hill and in states really do frame the need to fill the coverage gap as an urgent, necessary health equity issue. So definitely something to keep in mind. I don't know how much more you can really do to significantly move the needle without extending access in those 12 states. If you go to the next slide, we have to talk about the American Rescue Plan Act as well. I mentioned at the top, you know, this is really the first time that Democrats in Congress have been able to build on the Affordable Care Act. The American Rescue Plan Act was enacted March of 2021 and, you know, has a whole bunch of changes in it. The ones I'll focus on are 2 changes to marketplace subsidies. So it really increased the generosity of existing ACA subsidies. It did that in 2 ways. The first way was to increase the generosity of the subsidies already in existence. So for folks who already qualified, who are already eligible, it made those subsidies more generous. That works like a sliding scale. It just meant folks and families had to pay a little bit less in their premiums to get the same coverage. As an example, folks under 150% of the poverty level were previously asked to contribute about 2% of their income towards premiums. Under the American Rescue Plan, they could find a silver plan for free. There was no premium contribution there. So about 9 million people have benefited from that at a minimum, just much more generous subsidies under the rescue plan. The second sort of big enhancement under the rescue plan was to get rid of what we call the subsidy cliff. So under the ACA as originally enacted, if your income was above 400% of the poverty level, 410%, 405%, you didn't qualify for any financial help for premiums. And so the rescue plan lifted that subsidy cliff, extended subsidies up the income scale. It is not a free lunch. You still have to contribute about 8.5% of your income towards premiums, which is not insignificant in my book, but it at least gives folks some help. And I would really emphasize that policy helps a lot of people, and we've seen much higher enrollment of folks at that income level. But it really helped older middle-income Americans living in rural areas. And the reason for that is that's where premiums were often the highest. And so it extended a lot of relief to that population in addition to other populations too. And, you know, editorially, I do think the rescue plan subsidies and this debate that we're sort of seeing on the Hill about can you extend them, will you extend them? You know, this is a huge part of, I think, the unfinished business of the Affordable Care Act. And Democrats maybe always hope to do this. I wasn't sure it would ever happen, and in 2021 it did. Rodney knows better than all of us, I think, that so many of the design decisions of the Affordable Care Act were driven by the overall price tag and trying to keep the bill under $1 trillion. And this is an example of a type of policy I think Democrats had always hoped of coming back and making these subsidies more generous, and they at least did it for about 2 years. So if you go to the next slide, you can see that these subsidies are having a real increase in enrollment. They're having the impact that I think folks hoped. We saw record high marketplace enrollment for 2022, about 14.5 million people enrolled, which far dwarfs the prior record, which was about 12.7 million people in 2016. So you can sort of follow those trend lines. Enrollment had decreased year over year until the final year under the Trump administration. And then between rescue plan subsidies and the 6-month special enrollment period that the Biden administration put in place last year, you have really supercharged the Affordable Care Act. And we're seeing sort of record numbers of folks come in. You can see it on the slide, but enrollment has increased by about 21% over last year. So huge, huge gains there. In addition, about a third of folks found a plan for $10 a month or less. And that's a direct result of the American Rescue Plan. Chris, you mentioned this, those subsidies are temporary. So they do expire at the end of the year. December feels kind of like a long way off at this point, but there is increasing pressure to do this because insurance companies and state regulators and federal regulators are planning ahead for the plans they're going to offer. They're setting their premium rates. And so folks are trying to really game out or decide, how do we factor in this uncertainty if these subsidies are not going to happen or if they will. If Congress does not extend these subsidies, those 14.5 million people or so are going to start getting letters in the mail in October and November explaining that their premiums are going to go up significantly. One analysis said premiums would go up by about 50%, and about 13.3 million people would be affected. Of those, about 3 million are expected to be uninsured if Congress does not extend those subsidies. So I think this is a huge issue. It's also just one of the looming crises that are out there, including the potential for significant coverage losses from Medicaid at the end of the public health emergency. And if you'll go to my last slide, and I'm hoping this might be a good setup for Rodney, but I don't think you can talk about the ACA's anniversary without also talking about the law's popularity. Maybe folks are familiar with this data, maybe not, but you can see really significant shifts in the public's view of the Affordable Care Act over time. The law really had record unfavorability right around 2014. If folks think back, that was when there was all kinds of problems with healthcare.gov, the marketplace wasn't working, all these things. But sort of since then, at least beginning in 2017, when Republicans tried to repeal the Affordable Care Act in Congress, the Affordable Care Act's been doing well. The public views the law much more favorably than disfavorably. I don't want to overstate the numbers. I don't think we've ever hit 60% popularity, but you can see the trend that it does seem like the public thinks and understands maybe the law is here to stay and that people have begun to rely on it 12 years later. So I will stop there and turn things over to Rodney. Very happy to kind of wonk out, and I'm looking forward to the discussion. Thanks.
As always, a joy to follow Katie and work with her. Tim, thank you all for having me. So let me build off of where Katie just went and take it a little bit of a different direction. Okay, Katie talked about resiliency. The word I'm going to use is legitimacy. And I'm going to talk about the legitimacy of the ACA in ways that might surprise you a bit. So don't go rushing to throw in, nasty grams into Q&A already by raising that term. But let's talk about the ACA in terms of its political legitimacy, because I'm going to argue that one of the struggles we see with the ACA at 12 is that it still struggles with political legitimacy, enjoying broad political legitimacy. And I think it was even captured in Katie's last slide, how much there still is a diversity of opinion on the value and the favorable, unfavorable of where we've been with the ACA, even at a moment where we are arguably hitting peak ACA. If you look at the ACA as designed, as it was intended to function, as what we expected to see in the marketplace in the Medicaid space, we're at a high point in the 12-year history of the ACA. But even then, we struggle with the concept of legitimacy. Now, give me a moment to build out what I want to talk about when I use that loaded phrase, legitimacy. We have trade-offs that we look at in designing the policy here. In the Medicaid side, what we expect of states, what we expect of the federal government. On the marketplace side, what we expect of individuals, what we're going to subsidize on the government side. And that's a function of the nature of the way it works. Well, so is the Medicare program. If you step back and ask yourself, how does the Medicare program function? Well, you have your 65th birthday, you blow out a lot of candles, and then you start paying money over and over again, as long as you manage to stay alive. You're going to be paying premiums, co-pays, you're going to have deductibles, you're going to have, it's going to be a constancy of you and your relationship with the Medicare program. But the Medicare program is generally viewed with a political legitimacy, that the trade-offs that were made to achieve what is that split between how much we expect of the individual and how much we expect of the government to subsidize the individual, and then producing the coverage that flows with that, it's politically legitimate after 57 or so years. The ACA still hasn't achieved that moment where we see the political legitimacy in understanding how much we want to see people pay for themselves versus how much we expect the government to kick in. And I think that continues to be a challenge in making ACA and ACA coverage part of the fabric of our healthcare system, the way that I think we see in the Medicare program. Now, let's be clear. That's a very, very political conversation. It is a function of the 10-year war that we saw, Jonathan Cohn's book. It is absolutely part of the battle that went on and the fight over that legitimacy through all the court cases that Katie described, through the responses to the regulations, the healthcare.gov debacle, to the Trump administration and the ways they went about undercutting the ACA. It's part of an ongoing battle that we've seen. We're not going to unring that bell. It has happened. The question is, can we move forward on a political front to look at the ACA differently, to begin to be able to talk about it in terms of what's working right and what's appropriate here? I mean, Medicaid is a great example as we look at the question of political legitimacy. We're seeing fewer and fewer states now still holding out than we were just 3, 4, 5 years ago. Listen, it's going to be hard to get to all of them, but every year we chip away and we chip away and we chip away, and we'll see either through state action at certain levels or ultimately some sort of popular referendum of which the Medicaid coverage continues to win and win and win. It's because the political legitimacy, when you put the question to the voters, typically does go in the direction of, hey, this makes sense. We should be able to cover people. And so as that continues to happen, we'll see the political legitimacy of the Medicaid expansion continue to grow as we shrink the numbers. On the ACA side, it's going to be a continued challenge, particularly as we look at the conflict between Republicans and Democrats over the status of the ACA. Katie noted just somewhere in wandering around Iowa, my former boss, Chuck Grassley, said that he thought that there was no more conversation to be had about repealing, replacing should Republicans take over. That is not quite Nixon going to China, but it's a start. On the other side, though, Democrats also have to get to a different place on their side. And that is, they've got to decide that the ACA is written in pen, not pencil. And listen, if you don't understand what I'm getting at, what are we talking about right now with the ARPA subsidies? It is that Democrats wrote into a reconciliation bill, a partisan bill, that we want to change the nature of the trade-offs. They have had a significant positive effect. Crystal clear. I'm not arguing against that one little bit. If you look at what Katie sketched out, makes perfect sense. The more you subsidize individuals, the greater the coverage is going to be. Absolutely true. But at some point, to achieve the political legitimacy necessary to move forward, Democrats are going to have to put down the pencil. Okay, you can't come back to it again and again when you're in charge and say, let's take out the eraser here and make some changes. That's again down to the core of the legitimacy of the bill. And so I think that's really key to see moving forward, where we're going to watch things go with the Affordable Care Act. Can we find a place where political legitimacy can be achieved, where both sides put everything down and say, this is where we are. This is the marketplace. This is Medicaid. These are the trade-offs. We all agree to them moving forward. We're walking away from them on a fundamental level and agreeing this is where we are, and repeal and replace and Medicare for all and issues like that can be dropped so that the ACA can move beyond peak ACA, continue to thrive. We'll see how that goes. Well, let's face it, you're not here to see me, you're here to see Tim. We get to see Tim in person. It's a live Tim sighting. So I'm happy to hand it over to, and listen, I even wore maroon just to annoy a Washington LE guy, but our friend Tim Jost.
Huh. Well, it won't let me start the video. Well, can you hear me?
Yes,
We
we can
can-
hear you.
Okay.
Yeah. Rodney cursed it by saying a real live Tim sighting.
It should be down on your lower left, Tim. I think there
Yeah,
should be
it
a,
is, but it won't let me start it. I'm sorry. Well, I'll start talking and I'll just keep clicking it until it starts. It says cannot start video.
yeah, go ahead and start, and maybe the technical folks can see what they could do on their end. Sorry about that.
Okay.
Yeah,
well,
Tim,
thank you
I'm
for
sending
the-
you little reminders here too, hopefully you can click on them.
Okay, I'm sorry to waste everybody's time. Well, thank you, Chris, for the introduction, and thank you, Rodney, for your very generous comments. And it's still saying host asked you to start video, but you cannot start video, failed to start video camera. Oh, I don't know what it's doing. Well, anyway, let me just start. You don't want to see me anyway. On the morning of March 23rd, 2010, I took the taxi from my hotel to the signing celebration across the street from the White House. When I told my immigrant cab driver where I was going, he said he had had a hard time sleeping the night before because he was so excited that today he would be able to get health insurance. Little did he know that it would take nearly 4 years before ACA coverage was really available. And of course, none of us knew that the ACA would have to survive 3 trips to the Supreme Court, a very close late night vote in the Senate, and the relentless assault of the Trump administration before it become generally accepted as the law of the land. Today, it's stronger than ever, with 30 million people covered through marketplaces and Medicaid, and more receiving better coverage than they had previously. And also I should note, the Urban Institute said yesterday that the premiums have dropped for 3 years in a row for marketplace plans. The ACA has taken some major hits along the way. The most significant was the Supreme Court's unprecedented decision to make the Medicaid expansional option with the states, which has left over 2 million of America's poorest uninsured. Political considerations slowed the release of implementing regulations in 2012, and the initial crash of the website was very demoralizing. The Trump administration issued executive orders explicitly directing federal agencies to undermine the ACA, and the action those agencies took, like allowing association health plans to cover individuals or small groups under large group plan rules and expanding short-term plans, have in fact undermined ACA reforms. Over time, loopholes and gaps in the original act have also become more apparent in the proliferation of healthcare sharing ministries, the creation of Farm Bureau plans, and the spread of short-term and limited benefit plans. Some of these incursions into the A's have been fixed, but more needs to be done. The small group market reforms have been significantly undermined through level premium self-insured plans and association health plans and other schemes and scams. And the vision of a single risk pool small group market served by shop exchanges is largely lost. The proposed family glitch rule will help many with unaffordable employer coverage, but rules are still needed to fix short-term and association plans. The Biden administration must continue to repair damages that have been done. The ACA has survived because tireless advocates have fought for it and because it fills a significant gap in the coverage that is otherwise available in the United States. It also survived because the stakeholders affected by it, insurers, providers, and in fact the states, have mainly benefited from it. Opposition to the ACA is primarily ideological and not economic, although I do agree with Rodney that we need to have a continuing discussion as to the level of subsidies that are appropriate for lower middle class and maybe even some middle class people. Today, the coverage gains of the ACA face three major challenges, and two of these have already been mentioned. The first is the end of the public health emergency, which will mean that as many as 15 million people could lose Medicaid coverage. And although some of these may be ineligible, many of them will simply lose it through the administrative chaos that will follow from all of the redeterminations that have to be done. The second is the potential end of the American Rescue Plan Act enhanced subsidies, which may cause 3 million people to lose marketplace subsidies and erase the gains that have been made in the marketplace over the last 3 years. Then the third has not been mentioned yet, but this is ongoing litigation threats. I agree with Chris that at this point, there's no existential threat to the ACA, but there are still serious threats out there. One is a lawsuit currently pending before Judge Reed O'Connor in Texas, who tried to destroy the ACA in the California versus Texas case. He now seems poised to throw out the ACA requirement that health insurers and plans cover preventive services, one of the basic provisions of the ACA for people who are not eligible for subsidies. More generally, the ACA and all federal social programs are threatened by federal courts that seem determined to interpret the Constitution to limit the ability of federal agencies to help and protect Americans. And of course, even with the ACA, millions of Americans remain uninsured, grave equities remain in access to healthcare, the cost of healthcare remains far too high, and the quality of healthcare often leaves much to be desired. 12 years into the ACA, we still have much to do. In fact, my immigrant cab driver may still be waiting for the health care he needs. Thank you, and I'll turn it back to Chris for questions, and I'll start messing with my video camera to see if I can make it work.
So unfortunately, I'm also getting a message. The host has asked you, oh, there we go. Okay, I think I'm on now. No, it says you cannot start your video.
You're on now.
I am now. Okay. Sorry. We really, I don't know whether it was the maroon comment or the actual sighting, but we seem to, the gremlins are at least receding a little bit. So I think I wanted to pick up, and this has been raised a little bit by some of the folks in the audience as well. I was intrigued by one of the things that Rodney said, which was that basically we need to make sort of a grand bargain where everybody sort of, stops where they are, and the Republicans stop, repeal, and replace, but also the Democrats, put down the regarded as being written in pen and stop trying to write it in pencil and erase and add, et cetera. And the reason that intrigued me is because I've always thought that one of the, perhaps, looking at it the other way, one of the distinguishing marks of the ACA that makes it an oddity from other major pieces of social legislation is precisely the lack of changes that have occurred in it. If you look at Social Security, Medicare, they've all, there've been so many expansions, tweaks, et cetera. Medicare Advantage is another good example where, when there were periods where it looked like there were downturns in participation, the payment was increased, and now, if you listen to MedPAC, if anything, the payment may be too high. So I'm just wondering, and I guess I'd love to start with Rodney and maybe get Tim and Katie to weigh in. Is the problem with the ACA at the moment that we're trying to make too many changes, or that, we've made too few and that it's been a little bit frozen in place and hasn't been able to adapt like other pieces of major social legislation?
So I think the question is, and having been involved in the legislative process for a year or two when I was there, that for the place to function. Yes, I just acted as though the Congress functions, but work with me, okay? Work with me. That there has to be, again, a general understanding that the concept of what we agree upon is not subject to who's in charge. Okay? That if you make an agreement and you say, this is what we stand for, we held hands in 2000 and X, and we said we agreed upon it, then we meant it. And when I was there, that was what occurred. And my old friend David Schwartz and I cut a deal on something that well, I'll call it out, on the existence of MACPAC. And from then on, I felt like I was bound to believe that we cut a deal in good faith. We made a trade. I got something, he got something on behalf of both of our bosses. And therefore, moving forward, I was bound to say I supported the existence of MACPAC. Went directly to speak to them once upon a time. And I said to them, hey, if it was up to me, you wouldn't exist, but I cut a deal. And I've supported their existence ever since. That was the way Congress typically worked. What you can't have is a world where I would come back the next time that Republicans are charged and go, didn't really mean it, I'm going to get out the eraser and make MACPAC go away. And so that is part of, again, of a legitimacy of a legislative process where both sides come to agreement that this is really where we are. And that's what I'm getting at. In terms of whether or not you can, quote, improve upon the ACA, listen, adjust the dials to make it cheaper, make it more expensive. Doubt you're going to do that. We can talk about that, but there has to be at some point in time, and let's be crystal clear, the absolute worst thing for political legitimacy of the ACA is for, in the next X months, for Democrats to put in place two things: an extension of the ARPA subsidies for 2 years and an extension of into the 12 Medicaid holdout states, a 2-year extension there, putting it right before the 24 election and daring Republicans to say, we're done, we're not touching this again. That's only going to contribute to the problem. It may still happen, but it's not long-term healthy for PKCA.
Katie or Tim, did you want to weigh in?
Yeah, I mean, I would say that, well, Rodney knows a whole lot more about the way Congress works than I do. But I would say that, if you look at Medicaid and Medicare, every time we have a Budget Reconciliation Act, they change it. And I just think that that's not the way things work. The Democrats will continue to try to improve the coverage. I mean, I think there were some real mistakes made, and probably, I don't know, mistakes, but there were some things that I think were unfortunate compromises, probably because of the budget limit, essentially, that President Obama had imposed on the original ACA. And I think that they got some things wrong. And people who are at 401% of poverty and can't get health care insurance for less than 15% of their income, I'm not sure that they should remain uninsured. So I think it's a dynamic process. But I think that the basic idea that we will provide health care for the poor through Medicaid and health care for the lower middle class and the lower part of the middle class through subsidies, tax credits, is, I hope, pretty firm. And also the idea that we should have some kind of standardized insurance in this country for the individual market, I guess not for the small group market anymore, and that that people with pre-existing conditions should not be excluded from coverage. I think that one is pretty universally accepted. So I guess I feel like, yeah, we've got a lot of things that were agreed to and maybe we should stick by, but I think we can continue to tinker with it just like we do with Medicare and Medicaid every year or two.
Yeah, I had a couple of reactions. I think like CHIP is an example of a program where, like, I would have thought what you said was true, Rodney, where such bipartisan agreement to, fix a big thing. And CHIP has been something that in recent history has been used as like a political ploy in a different way and sort of unprecedented, right? Yes, and I think there are some shifts afoot, if you will. The counter is like the No Surprises Act, right? So I think there are examples sort of on both sides where you can still get stuff done. One strong reaction I'm having is that, would it really be the worst thing for Democrats to do these new programs for 2 years? I think you said it'd be the worst thing for the ongoing legitimacy, but from if you believe in getting relief to people and extending the programs and helping people, I am having a strong reaction that wouldn't be the worst thing. It might be the worst thing on some dynamics, but I don't know the worst thing that could ever happen to Democrats.
If I can just throw in a react, just to again,
Sure.
get you guys going on this. In this millennium, oh wait, it's a Tim Jost sighting. Is it?
We
Could it
have
be?
Tim.
Hi, Tim. We see you.
If
You
this is
do?
on camera, let's just be clear. Tim, if you got lottery numbers, throw them our way, because I'm hitting right now every time I'm cursing your camera. So I got to make the most of this moment. Okay, back on target. This millennium, I'm going to argue the most legitimate piece of legislation, significant healthcare legislation this millennium, is the Part D drug benefit. And in terms of its political reception, the way it is treated on Capitol Hill, the way it is treated as this works, we accept it, we agree upon it. There have been minor tweaks at most, and it is a function of the way it was created. Now, I can't unring bells and change 2009-10. I take lots of drugs to forget 2009-10, but that's the idea that we're going to get to a better place by continuing to prove, well, when we're in charge, watch us screw you over. Well, when we're in charge, watch us screw you. Not happening.
One of those changes to Part D was in the Affordable Care Act. Making that clear for what that's worth.
And
Well, interesting. We could continue that. Let me throw in another question that's related, and I'll mention very quickly, just so folks know that shortly after today's session, this will be archived, and the recording and the slides will be available on the Health Affairs site. Then with that, I mentioned, I think, in my opening remarks that one of the effects of the Affordable Care Act, or the ways that it's become embedded in the healthcare system, might be the way that we think about insurance. And obviously, that being that in the Affordable Care Act, you can't deny coverage or discriminate on the basis of pre-existing conditions. So there's no medical underwriting the way there used to be in the individual market. And I think that there are young people certainly who haven't really known any other reality other than that. So I think a lot of folks would say, really the way when we say insurance, what we mean has been changed by the Affordable Care Act. And indeed, even when the repeal and replace debate was going on, almost inevitably, whatever proposal was put forth, people would say, this preserves that, this covers pre-existing conditions. But then when you look sort of beneath the hood on the sort of practical level, there were a lot of questions. Was that really true? So I'm sort of curious what you all think about the extent to which, has there really been a fundamental shift as a result of the ACA in the way we think about insurance? Or is that a little bit superficial in that, if we do get tweaks, and I don't even want to confine it to the repeal and replace. It could be during the Trump administration. There were, I think Katie mentioned, the short-term limited duration plans, the association health plans. Are we only going to pay lip service to this and in effect try to push things that would undercut it, or has there really been a shift in what we want insurance to be?
I'm happy to start. I think there has been a shift, and I say that from the perspective of someone who teaches this to students. And Rodney, maybe you and probably Tim too, you've had the same, right? You really have to go back and explain what underwriting was and really walk through this. And some folks will go, oh yeah, my mom had to fill out an application and had a blood test and had all these things to try to get health insurance. I think the idea that you could start excluding pre-existing conditions from major medical, again, I think it'd be anathema. I think that, I think there are definitely fights at the margins around certain benefit categories, and some of that is all still playing out. But I I do feel like the world has so shifted in the past 12 years, even recognizing that pre-existing conditions haven't been covered since 2014. I think it's also why you get the strong reaction on short-term plans and some of these other plans that do have underwriting and don't do that. Folks, we've so shifted what the public thinks insurance is now that folks are so surprised that these products still exist. You don't read the fine print in part, or you're misled into buying something because you assume that the one thing folks know about the ACA is it banned pre-existing conditions. And so my sense is that it has really, I think, had a big shift there.
Tim or Rodney, did you want to weigh in or?
Yeah, I think that that's true in the individual market. In the small group market, I really feel, as I said, that we're kind of drifting away from that. I don't think we're drifting away from the idea that individuals should not be underwritten. But the association health plans, I know the ones that we recently adopted in Virginia, and the level premium plans, the premium is written on a group by group basis. So you could have a group with 5 or 10 people, and they've got one really sick person, and it's going to cost them a whole lot more than somebody who has, some tech company that has 10 young people. So, and I don't see a huge lot of complaining about that. It's kind of interesting. I think Rodney probably remembers that the problems in the small group market were a big part of what drove the ACA. And right now, I don't see a lot of people rising up and complaining about it, although I did see yesterday that somebody, who is predicting that small group rates are going to go up by 10 to 15% next year. So maybe we'll hear more of that. But yeah, I think in the individual market, that idea is pretty well accepted now, except with, short-term plans and a few other things. The religious sharing ministries, a few other things at the margins, which are not insignificant. 3 million people in short-term plans.
And I completely agree with what you both said, and I think this is, again, back to this my recurring thread here. I mean, again, I think we are closer and closer to the legitimacy of a standardized approach to health insurance, in that there are just certain minimum expectations, period. I'm not going to tell you that there aren't people who are going to shout liberty and say you should have the right to have nothing and pay consequence. I'm not going to bother, but I think in the whole, I think you can very quickly drive people to the position that there are certain minimums that you would expect here. And again, I think that's part of what should be part of an ongoing conversation, to reach that general consensus of what we expect as part of a nonpartisan approach to the core of what coverage is.
It's interesting. Let me go to a different direction. One of the questions that's come up was about the Medicaid expansion and the fact that, and I think a couple of you alluded to it, that it's been pretty popular where it's been implemented. And the question is that the 12 states, notably Texas and Florida, but also others, that in those states, what are the chances that we'll see progress? Rodney, I think you sort of alluded to, like, we're chipping away. What can we expect to see in terms of additional states perhaps expanding over the short term and intermediate term? Who wants to start?
I'll jump in and go that we are where we are here. And I'll say something inflammatory and let you two chew me up just for sport. I mean, hey, John Roberts had to come up with a political decision. He grabbed hold of Paul Clement's argument, which made no sense whatsoever. And next thing you know, it's controlling here. Who knew? But at the end of the day, it really is, if you look at, there are plenty of red states who've expanded their Medicaid. And it is simply a function of the rationality of folks to go, you know what? Actually, the consequence for our public hospitals, the consequence for our budgets, that all the reasons why other states are doing it successfully, maybe we should set aside our political animus for the existence of the ACA and address that. it's going to be harder to get there. Hey, one of the parlor games I play, when I'm at parties, which speaks to you very much about the parties I hang out and whether or not I should be in places like that. Okay, who was the last state to expand Medicaid and what year? What would you be willing to bet that it's going to take longer for the last Medicaid expansion state, and which state would you pick? Generally, I go like Alabama and never, but we play it out.
But how long did it take Arizona to adopt Medicaid? Wasn't it about 20 years, I think?
I believe it's 17, right, gang?
Yeah, there's still hope.
I would add, Rodney's right. There have been more states that have come online. They have almost been exclusively, if not exclusively, through ballot initiatives. And there are many states in those 12 states where a ballot initiative is not an option. And even in the states where you've had a ballot initiative, there's news out of Missouri, you've had legislatures or governors try to pull it back. Utah, Idaho, many of the states come to mind. I think there have been efforts on the ballot, and I want to say Mississippi, which I think a court said you couldn't do. I think South Dakota might be on the ballot, but the big states, I think Texas, Florida, Georgia, it's not an option or going to be really, really challenging. And so it is, when you have put it to the people, it always wins, it always succeeds, it's very popular. I don't know what it's going to take to overcome some of the political dynamics in some of these states. And would it be 17 years or not? And this is very much, I think, animating the discussion on the Hill of should there be some kind of federal fix, whether it's, a federal Medicaid managed care program in those states, which sounds like a nightmare to operate, or putting folks through the marketplace. But I think it is one of the most sort of what's the federal fix to this in light of the Supreme Court's NFIB decision. Very complicated policy-wise, politically, and frankly, legally, which I know is something that Rodney and I have chatted about before. I think, you have some constraints on what Congress can do based on that court decision. And so folks need to be really careful with the fix that they use. That said, it's framed as one of the biggest health equity issues of this Congress and something they could do to make progress there. So we'll see what happens. But I think the sense, rightly or wrongly, is these states are not going to come online.
Well, we have another question which asks for more detail on the challenge to the preventive services coverage mandate that Tim mentioned down in Texas. And I chuckled when I saw it because the questioner added, and why do these always seem to get to Judge Reed O'Connor? Which, has to do with forum shopping and all sorts of things. But this does raise, I think it'd be great to hear Tim and others talk more about that particular case, but it also raises the question of, is there any way that we can get away with having so much of our policy process going through the courts? Whichever side one is on, there's presumably got to be a better way than having every single aspect go to litigation. So maybe we could talk a little bit about that case, and then the broader question of whether there's a way to avoid having litigation be such a prominent part of the policy process.
The argument is that there are two constitutional, actually three, but I'll talk about two of them, constitutional doctrines that the preventive services requirement violate. The preventive services requirement says that the AKIP, Katie, what's that? I always forget the.
I'm going to screw it up too. It's the Vaccine Advisory Committee.
The Preventive Services Task Force and the Health Services Resources Administration shall decide the preventive services that insurers are required to cover without cost sharing in all markets. And there are two arguments. One is that Congress delegated the authority. Only Congress can make laws. It can, in some instances, delegate authority to administrative agencies if it kind of clearly tells them what to do. But in these cases, it didn't. And so it violates what's called the non-delegation doctrine. The second one is that these agencies are not appointed by the president, and their members are not appointed by the president and confirmed by the Senate. And so they violate the appointments clause of the Constitution. And it gets a lot more complicated than that. Like AKIP makes recommendations to the CDC, and the CDC director is properly appointed. So, but those are the things we're arguing about now in that case. But those two doctrines and probably a couple of others are really big now. I mean, there are other cases that are being brought about them in other fields, in environmental law and immigration law. And they basically have to do, well, it's basically about the division of power between Congress, the administrative agencies, and the federal courts. And some judges like Reed O'Connor and probably several justices on the Supreme Court would like to see the courts a whole lot more powerful and the agencies a whole lot weaker. And I guess Congress is sort of ultimately in charge, but we can see how much they're getting done right now. But the judges, I mean, forum shopping happens on both sides. And just to say one more thing about that, a really big problem is that Reed O'Connor and some other judges like to enter nationwide injunctions where they say, I've got 3 plaintiffs in front of me and I'm going to block the agencies from enforcing this law anywhere in the United States. And Jeff Sutton, who's a fairly conservative judge in the Sixth Circuit, wrote an opinion yesterday in a case saying, you know, this is not a good idea to have single judges, be they right wing or left wing, deciding the law for the entire United States as opposed to administrative agencies or Congress. That's my.
I might add 2 quick things. I think the preventive services challenge, right? We've seen so much litigation over the contraceptive mandate, which is one part of the preventive services mandate. This is a challenge to everything. And the plaintiffs are really picking up language from Justice Thomas in his decision in 2020 on the contraceptive mandate called Little Sisters of the Poor. I read this as like, by all means, bring me a challenge under the non-delegation doctrine. This reads like a really broad statute. And so folks are picking that up and they're before Judge O'Connor. I would also say I think the plaintiffs are particularly motivated by concerns, yes, about contraceptives, but PrEP, which is pre-exposure prophylaxis, which prevents HIV and is a historic, important medication. They're making a lot of religious and moral claims about PrEP, and also things like HIV and STI testing, some very, I think, common, important preventive services that they're trying to dismantle through that. And I guess one more point on Judge O'Connor, there's definitely forum shopping on both sides. I think Judge O'Connor is an example of judge shopping because there are many districts in Texas where you can go to a specific division. And if you file in that division, previously he was in the Wichita Falls division, he's the only judge. So if you file there, and the Texas Attorney General filed every challenge to federal regulations under the Obama administration in Wichita Falls, Texas, which is in the middle of nowhere. I grew up 4 hours from there. There's no reason we should be litigating in Wichita Falls. Now he's in Fort Worth. He's one of 3 judges. And so there's a very high likelihood that if you file in that division, you will get Judge O'Connor. So I consider it a pretty extreme example of forum shopping. It is almost picking the judge that you want.
And Chris, just really quickly to your comment about litigation. Hey, let's be frank with each other, which is, you know, when the courts rule our way, we love them. When they see them rule against us, we hate them. Now, in that sense, us in the healthcare advocacy space, we are painfully similar to NFL fans and the refs. Just stop it.
Well, let me, we're just about out of time. Let me see if I can get a 20-second question or 20-second answer. There was one other question we didn't get to that came in early, whether inflation is a threat to the subsidies in the sense, I guess, of really lessening their value. I suppose to the extent that it is reflected in healthcare inflation, it would get accounted for in the benchmark process. And, you know, so the subsidies might increase, but do you see sort of general inflation as as lessening the subsidies and being a threat in that sense?
As the furthest thing from an economist, Chris, my initial sense is I agree with you. I think that the way the subsidies are structured is actually protective of inflation. What I don't know is if it affects the CBO score and the cost of extending the rescue plan subsidies and that kind of, like if sort of getting a policy fix becomes more expensive as a result, but I don't know enough to know that.
Sorry, the relationship that the providers have, particularly working under tight MLRs, is where inflation can be a problem and a problem in a hurry.
I think Tim, did you want to jump in briefly?
Well, again, just, you know, I think to the extent that Medicaid, Medicare, and the Affordable Care Act become more and more and more expensive, it's going to be even more of a political issue.
Well, we are I pushed it. We were actually out of time a minute ago, but I did want to get an answer to that questioner. So with that, let me just remind folks that this will be archived, and the recording and the slides will be available on the Health Affairs site for folks that want to either re-listen or listen for the first time if they've missed it. I want to thank our panelists. It was a great discussion, and we could go on about nationwide injunctions and all sorts of things that have come up, and hopefully we'll do that next time. So thank you to the three of you, and thank you to everybody who's joined us, and we'll see you next time.
Thanks.
All right, well, thank you.
That was fun. Thanks, everyone.
Enjoyed it immensely.
All right. Bye, y'all.
Bye-bye.